Pattern 1 is probably discogenic. I put this in because I got very tired of people saying, well, what is the pattern? And I say, well, a pattern is a syndrome. The syndrome is a constellation of signs, blah, 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 for which we do not have an etiology. And they would say, right, what's causing pattern 1? And so I gave up and said it's probably discogenic. And it probably is. Discogenic pain is the most common back pain, and when you read the literature and you describe the patient, this is what people assume is disc. But please be very clear. I want you to make the call it disc, call it pattern 1, on the history and physical. If you have an image, if you have an MRI of a black disc, that does not mean the patient has pattern 1 pain. Okay, it only works in one direction. We're basing it on history, physical. You can make the assumption that it's discogenic, but you must base it on what you see and what you hear. It's back dominant pain. We know what that means now. It's pain that is worse with flexion. And that's why I asked you to bend forward. And it is the only pattern that allows it to be either constant or intermittent. So if it's constant and it's back dominant and it's worse on flexion, you're a pattern 1, for sure. It can't be anything else. The physical examination is exactly what you think it should be. It's pain in the back that's made worse on forward bending. So if you've told me it's worse when you bend forward, and I say bend forward, and you say, yeah, that's worse, that told me what I wanted to see. The neurology in pattern 1 will be negative because this is not root involvement. This is referred pain from a sore thing. And that thing is probably the disc, but whatever that is, it's the thing. So there isn't root involvement. You won't have deficit. If there is a deficit, it's unrelated to the pattern. You can have a deficit. I ruptured my Achilles tendon and I lost my ankle reflex. So there's a positive finding, but it's unrelated to my back pain. So there will be no correlation if there are any findings. Mostly it's just negative. Now, this breaks into 2 subsets. The first is better with 5 prone passive extensions. We call these people prone extension positive, or PEP patients. These are patients that have what the McKenzie therapists refer to as a directional preference. In other words, their pain is worse in one direction and it is better in another. They are easy to treat. A pattern 1 PEP patient, a prone extension positive patient, should be someone that you manage in your practice very easily because they've told you that this makes me worse and this makes me better. Now, in order to do this, you need to know how to demonstrate a prone passive extension. Now, the technique of this sloppy push-up, as I call it, the prone passive extension, there's only 2 elements of this that matter. They're very simple. It's a very easy thing to get your patients to do. It's done for the patient whose pain is aggravated on forward bending. And now I have to determine whether that forward bending pain is made better with this maneuver or not. They will either be positive, that makes them a PEP, or it'll make them worse, in which case they're a PEN. It's that simple. Now, the first thing I have to do is have you put your hands flat down on the table and push your shoulders up using your arms. Just raise your upper body. Push up, 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 up. Go, go. More, 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 more. All the way, all the way. Straight. Yeah, like a push-up, except I want your hands up here. Do a push-up with your hands up there. Now push all the way up. Perfect. Now, I've got to get him to a point where his elbows lock. That's the first and most important thing. If his elbows are bent, so just bend down slightly, all right, he cannot relax his back. You can try this, yourself. You can't do it. If your arms are bent, you're using your muscles. So once I lock his elbows, then his back can relax. Okay? The second element of this, go right down again, is that when he comes up, his hips, his anterior superior spine, ASIS, must stay on the table. So push up again, as I showed you. All right, now his hips have come up, so that's not good enough. So what I'm going to have you do is slide down the table a bit. Now put your hands up here. Now push up. Okay? Now his elbows are locked and his hips are down. I can probably get a bit better, so come just up a bit. No, go back up. I'm going to have you raise now. Now come up. Push up. hips down. Okay, there, I've got them. Hips are down, elbows are locked. That is the correct technique, and those are the only two things you have to check on, making sure the hips stay down and the elbows stay locked. Once I've got that technique, I need 5 repetitions. So go down, all the way down, come up, lock your elbows, sag your back, and go back down. That's 1. 2, up, lock your elbows, sag your back, and go back down. Small technical point. When I have him come up, lock your elbows, I put my hand on his elbow. Because when I say to these people, sag your back, what they do, of course, is they sag their elbows. So I keep his elbow locked, let his back sag, and then he goes back down. Okay? So 3, 4, 5. The number before, okay, we're all done now. We did our 5. When you came in, you said your number in your back was a 6. You've done 5 of these. What's it now? And if he says it's a 3 or a 2, then he's a PEP, and I know what to do for him. If he says, gee, it got worse, or couldn't even do it because it was so painful, then he's not. He's a PEN. He's a prone extension negative, and that's a different treatment strategy. They're both very clearly laid out. PEPs are easy. PENs are not. And we can get into that later on this morning. Okay, thanks very much. So no change, and that's a pattern 1 PEN. That's a prone extension negative. That's a different situation. And that is the commonest pattern of pain. That's discogenic, probably pain on flexion. Does it get better or not on repetitive prone extension? And that's it. That's the first group. So that's pattern 1. Anybody with pain that is back dominant, back, buttock, trochanter, groin, coccyx, is either a 1 or a 2. Okay, so that's the first thing to be clear about. If you're back dominant, you've got to be a 1 or a 2. If you're a 1, that back pain, that typical pain, is worse on flexion. End of story. That's all you got to hear. I don't care what happens on extension. To make the diagnosis of pattern 1, I need to know you're back dominant, constant or intermittent. If you're constant, you must be a 1 because 2s are always intermittent, and the pain is worse on flexion. On physical examination, I will discover what happens when you extend. If you extend in standing and your pain goes down, you must be a PEP, a prone extension positive, because if standing extension makes you feel better, then an unloaded passive extension will also make you better. And the treatment for pattern 1 PEP is just do lots of extension. You know, pretty simple stuff. Pattern 1 PEN is the patient whose pain is aggravated on flexion, that's why he's a 1, and is also aggravated on extension, including prone extension. So I give you a prone extension, and either you can't do it because it hurts too much, so you don't even give me 1, or I get 3 or 4 from you, and then at the end of that you say, oh, it's worse than it was, the pain is worse now than it was before I did it, so now you're a pattern 1 PEN. Now, there's a condition that I didn't mention in the talk, and I had a couple of therapists rush up and talk to me about, and that's a thing which is termed centralization. Have you heard this term? If you don't know it, occasionally when I do an extension exercise and the patient's getting better, they're a PEP, the pain does not disappear, it moves. It shifts from the location over the buttock, wherever it was, into the midline. And in fact, occasionally it becomes worse in the midline. It actually goes up, but it's not in the same place. It's not the same pain. It's not this pain anymore, it's a midline pain. And that phenomena of the pain shift is called centralization. It's been well recognized, it's well established, and it is a sign of improvement. The flip, peripheralization, is bad. So if the pain started here and I did 5 sloppies and now the pain is radiating more down your leg, that's a bad thing. So either pain reduction or centralization is a good thing. If you're a pattern 1 PEN, extension will make you hurt, just like flexion will make you hurt. And it often makes you hurt more. These people often hurt worse going backward than they do going forward, which is why they get fooled into thinking they're a 2. Because, you know, oh, extension hurts, that's a 2. No, no, only if there is no pain on flexion. So, how do I treat this person whose pain is this way and really this way? Well, I start them in an unloaded flexion. I simply put them down in a Z-lie and I just leave them there. Leave them there for half an hour and see what happens to their back pain. Pad them up with pillows and make them comfortable and just see what happens. And in the majority of cases, that alone will reduce their pain. Now, it won't last. They get up and their pain comes right back. That's okay. But I know which way we're heading now. So I will begin them in a flexion position. I move from there into flexion movement. So now it's knees to chest or stretches or yoga, whatever you want it to be, but it's unloaded and it's flexing. I will progress them from that to extension. I'll turn them over, put them over a pile of pillows or flat or up on their elbows, doesn't matter. Figure out what works best. But now they're in an extension position, because ultimately, remember, pattern 1s want to extend. And then when I get them comfortable in extension, I will start them moving. And I will start them doing the sloppy push-up, the passive extension. And it'll be very low level. I'll have their hands way out in front so that the amount they can actually elevate is quite small. And then as they loosen up, if you will, I can gradually bring the hands back. I can increase the amplitude of the extension, and eventually they become pattern 1 PEPs. So a pattern 1 pen is treated slowly by moving away from the ultimate goal and then coming forward as quickly as I can. How far back I go and how quickly I come forward is patient dependent. And each patient is different. Some need no more than just put them in an extension position for a little while before I start moving them. Some need to go all the way back to lying in a Z-lie before I can even begin to bring them forward. It's time consuming, it's tedious, they flare up. That's the other big thing about pattern 1 pens. They're the ones that flare. They're the ones that you think you're doing it right, and then they'll come back and say, oh my God, made it worse. And you get all scared and think, oh my God, I've broken something, which you haven't. It's just a pattern 1 pen response. But that's why, and I laughed about it this morning, that's why I send those to see the therapists, because they can deal with that nonsense, and I'll take care of the PEPs myself, because that's just teaching them to do a sloppy push-up. It's a real, I find them fascinating to deal with because you keep sort of listening to the patient. This is really what it's all about. Listen to the patient. You're not going to break anything. Nothing's going to happen. You're just going to control their pain, and you do it based on their response to what you give them. And all I'm saying is in this pattern, that's the progression that you take. Pattern 1, it's pattern 1 PEP, it's just extensions. Pattern 2, it's all about flexion, stretches, and that thing in the chair where you just bend forward. Pattern 3 is all about Z-lie or hands and knees or whatever it takes to reduce the leg pain. And pattern 4 PEP, the unusual group, treat them just like pattern 1 PEP. Everything I said about pattern 1, sloppy push-ups, this is just a intermittent leg pain, which is exactly the same as the intermittent back pain. And then the final group, pattern 4 PEN, which is the neurogenic claudication, the big group, that's core strength and posture. And as I said earlier, the only place where surgery has a better track record than non-op.